Welcome. Today we're taking a focused look, a deep dive into a condition called HSPB8 myopathy.
That's right. It's an ultra-rare muscle wasting disorder, slowly progressive.
And our goal here really is to get into the details of when you, as clinicians, should suspect this condition, given how uncommon it is.
Exactly. It's also known, perhaps more technically, as myofibrillar myopathy type 13 with rimmed vacuoles. It all comes down to mutations in the HSPB8 gene.
Okay, HSPB8. Now, I remember reading that this gene wasn't initially linked directly to this type of myopathy.
Correct. Initially, mutations in HSPB8 were associated with neuropathies, specifically Charcot-Marie-Tooth type 2L, and also distal hereditary neuropathy type IA.
Right.
It wasn't until, I believe, 2016, Gowie and colleagues published work linking these mutations specifically to this myopathic presentation.
That's fascinating. It really highlights how our understanding evolves, doesn't it? One gene, multiple potential phenotypes.
Absolutely. It underscores the complexity. So discerning the clinical picture becomes even more crucial.
So let's get into that. What's the typical starting point? Age of onset, for instance.
Generally, it tends to manifest in the second, third, or perhaps fourth decade of life. So we're talking young adulthood, middle-age onset typically.
Okay, not typically pediatric or late life onset then.
Less commonly, yes. The key characteristic, the real hallmark, is progressive muscle weakness.
Progressive. And does it start in a specific pattern? Like arms first or legs?
It can vary. That's one of the challenges. It might start proximally so, hips, shoulders, closer to the trunk, or it could begin distally, out in the hands, or, more commonly, the feet and lower legs.
Okay, so variable onset location.
Variable onset, yes, but there's a strong tendency for it to predominantly affect the lower limbs initially, even if it starts elsewhere or spreads there quickly. That lower limb involvement is quite characteristic.
Right. So a young adult presenting with weakness, especially in the legs, that's getting worse over time. That should be a flag.
Precisely. That gradual decline should definitely make you think.
Beyond just weakness, are there more specific things patients complain about? Things you'd hear in the history?
Yes, definitely. Often the first thing they notice is just difficulty walking. Maybe they're tripping more or their gait feels off. This usually appears in early adulthood.
Okay.
Then, tied into the weakness, bilateral foot drop is a very common finding.
Ah, so difficulty lifting the front of the foot.
Exactly. Leading to that tripping or needing to lift the leg higher when walking. Foot and ankle pain can also be quite prominent.
Pain isn't always highlighted in myopathies. Interesting.
It seems to be a feature here, yes. Patients might also specifically mention trouble with overhead activities, reaching up to shelves, for example.
Right.
Or difficulty getting up from a chair or climbing stairs. Those tasks requiring proximal strength, even if the onset was distal.
So it can spread, affecting both proximal and distal function over time.
Correct. And as things progress, balance can become a significant issue, leading to more frequent falls.
Falls, okay. And you mentioned respiratory issues.
Yes, but typically later in the disease course. Difficulty breathing might develop as the respiratory muscles become involved.
Got it. So history gives us clues. Progression weakness, often lower limbs first, foot